Respiratory distress in newborns is characterized by difficulty breathing. It is observed through signs such as rapid breathing, grunting, nasal flaring, retractions, inward movement of the chest wall, and cyanosis, bluish color of the skin due to lack of oxygen. It is a common condition, affecting approximately 7% of newborns. The incidence is higher in preterm infants due to their underdeveloped lungs. The causes can be diverse, including respiratory distress syndrome (RDS), transient tachypnea of the newborn (TTN), meconium aspiration syndrome, pneumonia, and in rare cases congenital abnormalities of the lungs or airways. Prematurity is the most significant risk factor. Others include diabetic mothers, cesarean delivery without labor, and perinatal asphyxia. Respiratory distress syndrome (RDS) has been known as hyaline membrane disease. RDS is primarily due to surfactant deficiency in the lungs and is more common in preterm infants. Transient tachypnea of the newborn (TTN) is caused by delayed clearance of lung fluid and is more common in full-term or late preterm infants. It usually resolves within 1 to 3 days after birth. Meconium aspiration syndrome occurs when a newborn inhales a mixture of meconium, first feces, and amniotic fluid into the lungs around the time of delivery, which can block airways and cause inflammation. Neonatal pneumonia can be acquired in utero, during delivery, or after birth, leading to respiratory distress due to infection in baby's lungs. Diagnosis of respiratory distress and its causes involves clinical assessment, blood tests to check oxygen and carbon dioxide levels, chest X-rays to view lung condition, and sometimes echocardiography to rule out heart-related causes. Management depends on the cause but includes supplemental oxygen, mechanical ventilation, administration of surfactant for RDS, antibiotics for infections, and supportive care. Surfactant therapy is a critical treatment for RDS, involving the administration of surfactant to the lungs to help keep them open and reduce the effort needed to breathe. Prevention strategies include proper prenatal care, management of maternal diabetes, steroid administration to pregnant women at risk of preterm delivery, to accelerate lung maturity, and avoiding unnecessary cesarean deliveries. Prognosis and outcome depends on the cause of respiratory distress, gestational age at birth, and the promptness and effectiveness of treatment. Most full-term infants with TTN recover completely, while preterm infants with RDS may face more complications. Some infants, especially those born preterm or with severe respiratory distress, may have long-term respiratory problems, such as bronchopulmonary dysplasia, BPD, or asthma, and require ongoing medical follow-up. More about respiratory distress and its management in the NICU will be discussed by Dr. Stola on Sunday. Thank you.